Meredith, I'm not going to lie. We're getting late in the SHM day.
Mm-hmm.
I'm a little worried about it.
Why?
I don't know, but I'm pretty sure it'll be a joint effort, so we'll be good.
Oh, that was good, Moni. That was a pun.
I know. I thought of that when I was at our guest talk, and I was pretty proud of myself. So
way to go.
I'm glad that it landed better than my attempt yesterday.
Yeah, that we cut.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
And welcome back to Curbsiders. I'm Dr. Moni Amin, here with my effervescent co-host, Dr. Meredith Trubitt. How are you this day?
It is the afternoon.
Wonderful.
I did have to think about it as well. I'm doing well. How about you?
I'm feeling lucid, which is about as well as can be said right now. So having a great time. Again, we're here from SHM Converge 2025. Just got out of some great sessions, and a session in particular we wanted to bring in episode form was Rheumatology for the Hospitalist. And in a second, I will tell you a little bit about our guests. But before we do that, Meredith, will you please remind the good people in the audience what it is we do on this show?
Sure, Moni. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge.
Great. And our guest today is, I just got out of her wonderful talk on rheumatology for the hospitalist, Dr. Kimberly Trotter. She's an assistant professor of medicine at the University of Chicago. She did med school at the University of Maryland and then trained at University of Chicago. And she's the co-director of the Lupus Center at UChicago. Welcome, Dr. Trotter.
Thank you so much for having me.
Awesome. Well, should we do some questions, rapid fire?
Yeah.
Go ahead.
So usually to get to know people, we like to ask fun questions. And I know there's stuff written there, but usually on these trips, we like to ask specific to where we are. So anything that you like to do while you're in Vegas?
Oh, that's a really good question. So I really love coming to the shows in Vegas. I've seen a couple of good ones over the years. And this time I'm here with my mom. We're going to see a singer from the 1970s tomorrow night.
Who's that?
George Benson. And so I had not heard of him, but I went and listened to his songs. So I do know some of his songs.
Sweet. Is it somebody your mom's a big fan of?
Yeah.
From the 70s, yeah.
That's awesome. Do you want to just do picks of the week?
Yeah, let's do some Vegas themed picks of the week. What you got?
Oh, man.
Back to Moni. So mine's an upcoming because I am not done with Vegas this year. I am coming back twice this year to see my homegirl. Oh, yeah, you guys guessed it, Kelly Clarkson. She's starting a Vegas residency. She did one a couple years ago at Planet Hollywood. This time she is at a institution much more of her stature, Caesar's Palace at the Coliseum there. So very excited and to meet my fan friends that I like to hang out with when I go. So that's coming up and I'm super pumped. It's really the only reason I would come back in the same calendar year.
Yeah.
About you, Meredith?
I'm going to just shout out our dinner last night.
Yes, it was very good.
Yeah. It went through a lot of iterations to review and everything, but it was an entirely plant-based menu, which when your hospice group is half vegetarians, it was a really good find, I thought. And outside of the restaurant being super dark and then having to walk back out into the casino after that, I thought it was a good time.
No, it was great. And it didn't seem like people who ate meat like yourself seemed to miss it too much with the meal, which is the sign of a good...
They did a great job.
Yeah.
So, yeah, that'll be my pick.
And the pick was Crossroads Kitchen.
Yes.
Want to make sure we clarify what that was.
Yes, at Resorts World.
All right. Meredith, will you please get us to our first case from Cashlack?
Sure. So we're going to start with a gentleman, Mr. Small. He's a 57-year-old, and he has past medical history of hypertension and diabetes, and he presents to the emergency room with gradually increasing shortness of breath and lower extremity edema for the last 2 weeks. He's never had these symptoms before and is quite concerned. His meds at home include metformin, hydrochlorothiazide. He doesn't smoke, but he does drink 1 to 2 12-ounce beers nightly. He denies any street drug use. Vitals are stable in the emergency room, but they placed him on 2 liters of oxygen because of low saturations. His physical exam is notable for JVP, 3+ pitting edema, and bilateral basilar crackles. Bedside echo shows a new reduced EF of 40 to 45%, and patient is admitted to the hospitalist service for IV diuresis, and they go ahead and start his Lasix. Over the next couple of days, he's diuresing well, but on the third day of his admission, he complains of new onset left big toe pain. He states that it started overnight and he is unable to move the toe. On exam, it's red, swollen, and it has decreased range of motion and is exquisitely tender to light touch. So this seems like an arthropathy, and as a hospitalist, I feel like the most common thing that I encounter is gout. However, I just wanted to take a minute maybe so that we can go through what our differential really should be at this stage.
Sure. So I would agree. The findings in the first toe always make us think about podagra, the fact that it's acute onset, it's really painful even to light touch. Those are all clues for gout. I also want to throw out CPPD arthritis. It's less common in that first toe, but it's something that can mimic gout, and that's what we also know as pseudo-gout. A couple of other things to think about on your differential. I'd put them a little bit lower in this case just because of how acute the symptoms were and how painful they seem to be. But osteoarthritis of the first toe is also super common. I would say a key difference, these people don't tend to have as severe of pain or acute of onset as you would think for crystalline arthritis. And they tend not to have the same features of inflammation. So the swelling, the redness, the warmth that you would see with an inflammatory arthritis. Other things to think about, trauma, they're in the hospital, but we know that trauma can still happen there. And then infection is something else to think about. If it's limited to the big toe, that's a little bit less likely, but these are the things that I would include in my differential.
And so when you walk in and you're like just hearing about it for the first time for the hospitalist, what are some other things like on history and physical that may like help you kind of prioritize that a little bit better?
One of the main things with gout is the severity of the pain. So patients really describe this really sudden acute onset, came out of nowhere. It's severe pain. So even just barely touching their skin, they're jumping off the exam table. So those are really classic findings for gout. Location is another key finding. So that first toe is pretty pathognomonic for what we call podagra in gout. Other things to look for are signs of inflammation. So if their joint is red, if it's hot, if you see a lot of swelling, and then many times these patients really have a lot of disability. So they're unable to move the toe at all. They're unable to put any weight on their toe. So these are all clues that make me think this is more crystalline arthritis versus other etiologies.
Okay. And we specifically, as the hospitalist, I think, picked this case where I think all of our listeners for a hot minute were like, I thought this was rheumatology, but this case sounds like heart failure again. And so I always think about gout, especially like in patients that I'm diuresing, but are there other kind of, things that can kind of acutely happen in the hospital that could still kind of trigger that gout flare for someone? Is that like secondary problem that's happening in the hospital stay?
So a lot of patients can develop gout while they're hospitalized for other things. As you said, I think cardiovascular disease is one of the biggest risk factors. So patients are coming in, they're getting IV diuresis, they're having a lot of fluid shifts. That's definitely a major concern with those patients. But there are several other risk factors. So patients who have kidney disease and they're coming in with an acute kidney injury, they're also at risk for gout. People who have underlying hypertension and may be on certain medications such as hydrochlorothiazide. And there's a whole long list of other medications that can also be associated with gout. These are some of the other risk factors to think about.
Yeah, I think, and the other thing about the case that I think the reason we picked it in particular was this is a new diagnosis of heart failure, and it's essentially a new diagnosis of gout, presumably gout. And so I think there's a couple things that come up for the hospitalist that are important. So the first is, how important is a confirmatory like arthrocentesis and like aspirate?
So whenever possible, we would recommend aspirating the joint. The only way to fully diagnose the gout is to aspirate a joint and visualize those crystals under the microscope. So whenever possible, please try and get the joint tapped. It's not always possible, though, with patients for various reasons. I would say the first MTP, the first toe, is really hard to aspirate and actually get fluid out of. And it's also super painful for the patient. So that's one where you may have to rely more on your history taking and your physical exam. Other times, patients may also just refuse arthrocentesis. They don't want to go through with it. But whenever possible, I would highly recommend getting arthrocentesis to confirm the diagnosis.
And to clarify, that would be every single time they come in and this pops up?
So that's a good question. Definitely if it's their first flare, I think that's really important to get the diagnosis. If someone is coming in and they have a monoarthritis, that's another case where I think it's important to tap the joint. If a patient has a known diagnosis of gout, they're coming in similar to their prior flares, especially if it's involving several joints. Those are patients that you could defer the joint tap to.
Okay. And then one of the things I think I realized as I was going back through the script just now and then comparing it to the talk today is I'm not sure you actually mentioned a uric acid level. And that's probably by design. So is that necessary? I'm assuming not.
So uric acid levels are great, and we use it especially when we're thinking about their long-term gout treatments. In the acute flare, it's a little bit trickier. And that's because a lot of times when patients are having acute flare-ups, their gout levels are artificially low. So for example, I had a patient once who came in with a swollen wrist. For all other reasons, we thought that this was gout. It was acute onset. It was super severe. Their uric acid level was 3, which is very low. They ended up going to surgery and actually aspirated the gout crystals at that time. And then when we saw them back in clinic, their gout level has shot up to 8. And so that's just to show you that really the gout levels can be super low during an acute flare-up. I think it's still good to get a baseline just so you can know where they're at, but it's not going to help you diagnose gout.
And so is it like for those patients that we were saying, like the arthrocentesis is super important for new flare, but maybe less important if it kind of comes back as like a classical presentation. Is your uric acid then any more beneficial on those like repeat flares? Because it's still going to be low in that setting, right?
Right, exactly. So during the acute flare, it's not as helpful. It's really good once the patient's outpatient, the gout is quiet, to get the uric acid levels.
And then any utility in imaging at this stage?
I think in this patient, you don't necessarily need to get imaging. The history, the exam all seem pretty consistent with gout. They don't have any prior history of gout, so it's unlikely that they're going to have bony damage there. Times I would think about getting imaging is if the patient had maybe trauma or if they're not responding to therapy as you would have expected, to look for other etiologies like maybe infection.
Okay. So for this patient, we do the arthrocentesis because we're doing everything by the book, and it's new onset. So can we, for a friend, review what the crystals are for gout versus pseudo-gout under the microscope?
Sure. So in order to see crystals, you have to use a special polarizing microscope. And this is what allows you to see the shape of the crystals and what we call birefringence. Under light microscope, you can't see the crystals. So under the polarizing microscope, gout, what you're looking for are monosodium urate crystals. These crystals are needle-shaped. They're also going to be yellow. And so this is negative birefringence when parallel to the axis on the microscope. So when you look on these special microscopes, there's actually a direction which shows you if it's parallel or perpendicular. So it's yellow when parallel or negatively birefringent. If you toggle the switch, it turns blue when perpendicular. CPPD crystals, these are calcium pyrophosphate dihydrate crystals, and these are rhomboid or rectangular shaped when you look under the microscope, and they're positively birefringent. So they're blue when parallel and they turn yellow when perpendicular.
And what makes it important to differentiate those two for like acutely in the inpatient setting?
So acutely, the treatments are pretty similar for gout versus pseudo-gout. You want to make sure you have the right diagnosis long-term because long-term treatments are very different. So for gout, you're really focused on getting that uric acid level down and you're using medications that target that, whereas those same medications, the urate-lowering medications, aren't going to work for pseudo-gout.
Awesome. So after looking under our microscope, we see negatively birefringent crystals and diagnose this as gout. I often think of like gout in the inpatient setting as opposite for what you just described, which is I only care about what's happening acutely and don't so much care about what's happening on the outpatient side. But when I was like going through the guidelines and everything as we were prepping for this, it became more clear to me that there's a lot more overlap between those two moments. And so I do want us to talk a little bit about what, should be like first line therapies for the acute, but kind of maybe also go into a little bit of that long-term management.
Great. So there are several treatments that we can use to treat acute gout. I'll start with colchicine. I think that's one of our most common medicines we reach for when thinking about acute gout. This patient, their symptoms, I believe you said, started just the night prior, so they're an excellent candidate for colchicine. Colchicine only works if you use it at the start of a gout flare. If the flare's been present more than 36 hours, colchicine's not going to work, and I would choose a different therapy. NSAIDs are also an option, probably not the best option in this patient, however, because they're coming in with heart disease, they have new onset heart failure, they're being diuresed already. So I would avoid it in this patient, but in a patient who doesn't have any contraindications, NSAIDs are a great option. A person who only has one joint, maybe two joints, an intra-articular steroid injection is another reasonable option, and it works really well for the first toe or podagra. It's just very painful, but that's a great option for this patient as well. And then we also use a lot of oral steroids. So generally what I would recommend is starting with prednisone 40 milligrams or the equivalent. Generally, you're going to continue that dose until the patient starts to show improvement, and then you want to taper. Usually you can taper most people off steroids within, 10 days or so.
And would you favor so in someone who could do an NSAID, would you still favor the colchicine over the NSAID, or it's a wash?
I think in that case, you can pick either. If you go with the NSAID and you see that they're not improving within the day, I would go ahead and try the colchicine just because you are on a shorter window with colchicine.
And for the NSAID, any of them, or like classic, like indomethacin?
I think the classic we all learn is indomethacin, but really you can use any of them. There have been some studies looking at different NSAIDs, and they haven't shown any difference between the different types.
And dose does not matter either?
So there is some standard dosing. Usually it's with indomethacin, it's TID, but I would use the standard dosing for the NSAID, higher doses than you would use over the counter.
Okay. And then same for the colchicine, because I think sometimes we fear colchicine a little bit, especially for like our patients with kidney disease, which is everyone also in the hospital. So anything of kind of how to think through that dosing and everything?
So colchicine is a little bit trickier. It does have a lot of medication interaction, so you definitely want to run their MAR and make sure that there's none of those before you give someone colchicine. If they do not have stage 3 kidney disease, you can use standard dosing, which is 1.2 milligrams at the start of a flare, and then we give 0.6 milligrams an hour later. And then you can continue that 0.6 milligrams daily to twice a day until the flare resolves. And generally, you want to continue that a day or so once their symptoms are gone. Where it becomes tricky is if the person has renal disease. So generally, if the creatinine clearance is less than 30, you could try the acute dosing, the 1.2 milligrams, and then the 0.6 an hour later, but you do not want to continue daily colchicine dosing. Also, if someone is already taking colchicine at home because they have a known history of gout or they're taking it for other reasons, you don't want to use colchicine as your acute treatment.
And I think you said it, but like the time of resolution of symptoms, it looked like its resolution counts as like, okay, symptoms are completely gone, and then you do the additional 1 to 2 days either for colchicine or for the NSAID or the steroid. Like for all of them, it's the same kind of taper off of the medication.
So yes, for the colchicine and the NSAIDs, and with the steroids, hopefully once you start the steroids, their symptoms are going to start improving within the next few days. And then by the time you're down to, 5 milligrams or so, the symptoms should be gone.
And so so for the steroid, then do you start the taper like immediately, or?
So I would wait until they actually start showing signs of improvement.
Okay, I gotcha.
Yeah, and I think in your talk you specifically mentioned, and I think as you just said that, it kind of clicked, those like sort of pre-packaged Medrol dose pack type things, those are not recommended because of the possible for rebound if you're immediately tapering. Is that why?
Yes, exactly. Yeah. So a lot of times we'll see people who got steroid packs in the ER, they gave them prednisone 40 milligrams for 5 days, and then they show up in our clinic and the gout is even worse than when they first came in with it. So definitely avoid those short bursts of steroids.
So those are all the ones that I feel super comfortable with because I've seen them, I studied them. And then the ones that kind of came in vogue as I was shifting out of training were the IL-1, so anakinra, and then I will not try to pretend to pronounce the other one. So can you talk a little bit about those?
Sure. So there's two. Anakinra is the most frequently used one. Generally, we use this for people who are not tolerating the standard of care therapies, or really they're just refractory. They're not responding after several days of these treatments. Anakinra is given as a subcutaneous injection. Generally, people need several days of this to maybe even up to 5 days of treatment, and then you can switch them back to the other treatments. And again, it works really well. It tends to work really fast. So it is something that we reach for when people truly are not responding. Canakinumab is the other IL-1 blocker. So this is a subcutaneous injection ×1. We do not tend to use this in the hospital, and really it's a big cost difference. So anakinra is maybe $1,400 versus one dose of canakinumab is $17,000.
Yeah, that kind of blew my mind when you said that at the talk. I was like, that just seems like not real.
Yeah. So thinking about cost is always important.
For sure. And Meredith kind of started this section with the referring to sort of like, the longer term therapies or things that we need to be thinking about even when someone's here in the acute setting. So can we talk a little bit about like, do we start at that first time they come in with that admission, or do we wait a few admissions before we think about maybe starting the longer term stuff and like how much and what and all that stuff?
Yeah, so I think this is a little bit controversial. So there are some indications where you would start urate lowering therapy up front. So these are patients who have stage 3 CKD or patients who have tophi or erosions. Otherwise, this is this person's first gout flare. So in this case that we presented, you don't need to start urate lowering therapy right away. Where I would start thinking about it are these people who are coming in back to back and they keep having gout flares, whether it's primary gout or they're in the hospital for heart failure or other things and they keep developing gout flares. So those are the people that I would think about starting allopurinol before they leave the hospital. What we find is, a lot of times it's deferred to outpatient, but unfortunately the patient doesn't make it to their outpatient appointment, or they get readmitted before they get to see their primary care doctor. And then it's this cycle where they just keep having, flare after flare, and they never actually get started on medications to prevent the flare.
Yeah. And do you start it like they come in, they get the flare, and you start both the acute treatment and the long term, or do you kind of wait as they get closer to discharge?
I would recommend waiting until they get a little bit closer to discharge. That way, if they have side effects or they're not tolerating one of the agents, then you know which medication is doing it. This also gives you a chance to make sure that they're improving on the therapy that you're giving them.
Yeah. And, allopurinol is like the one that I'm most comfortable with, most familiar with. Then these two newer kids on the block, the febuxostat and pegloticase, I think is how you say it. When do you pick those over allopurinol, or are they used in tandem? I truly don't know.
So allopurinol is still going to be your first line agent. So we recommend, unless the patient is allergic to allopurinol, they have a side effect, to start with allopurinol. Generally, we start with 100 milligrams a day. And I think for the hospitalist, that's the dose that you would start, and then they can titrate it as an outpatient. If a patient has stage 3 CKD or higher, then we recommend starting with allopurinol 50 milligrams. And the rationale for starting low and titrating up slow is it decreases the risk that you're going to have allopurinol hypersensitivity syndrome or other severe cutaneous manifestations from the medications.
Gotcha. And then the other two kids.
Yeah. So febuxostat is another option. It's another xanthine oxidase inhibitor. Usually we use that if you can't tolerate allopurinol, you have an allergy to it, or if you're just not getting to that goal uric acid with the allopurinol alone. The other times I'm starting to reach for it a little bit more. It's a little bit more affordable now. So if you're starting with 50 milligrams of allopurinol, and you're not titrating that until every 4 weeks, or in reality, you're seeing these patients every 2 to 3 months, it can take a really long time for the patient to get to goal uric acid. Febuxostat has 2 doses, 40 milligrams and 80 milligrams. So you get up to your goal uric acid a lot quicker than you would with allopurinol. And then pegloticase is another option. Usually this is reserved for patients who have really severe gout. These are people who have lots of tophi, they have lots of erosions, lots of damage. And again, patients that you really just can't get to goal uric acid with the oral medications.
I just wanted to go back for a second and talk about the allopurinol hypersensitivity syndrome, because I don't know that I've ever seen that. And so I just kind of wanted to know a little bit more about like clinically what to look out for and what that looks like.
So the main thing that we caution patients on is if they develop any rash, because there's a wide spectrum of rashes that can happen with allopurinol. So I tell patients, if you develop any rash, just let us know right away. Allopurinol hypersensitivity. So these patients, in addition to kind of when I've seen it, it's been a maculopapular diffuse rash. They can also have systemic features. So they may have fever, they may have eosinophils, they may also have some kidney dysfunction. So there's some other things that you want to watch out for. And then allopurinol has also been associated with other severe cutaneous manifestations like Stevens-Johnson syndrome. So there's a wide spectrum, and it's important to counsel your patients just to let their physician know right away.
And the recommendation would be to stop the med.
Definitely. Yeah.
Do you ever trial it again, or usually not?
Usually not. In that case, I would try febuxostat instead.
Got it. Okay. I guess while we're talking a little bit about like long-term therapies, and I'm going to go rogue for a little bit, but when we were talking about the reason you needed to know why it's gout versus pseudo gout is for the long-term therapies. So then the pseudo gout, like you're not using like allopurinol or any of the urate lowering ones. So can we just quickly remind me and probably other people in the audience what those therapies would be?
Sure. So CPPD arthritis is interesting because there's several flavors. So I think the most common one we think about is pseudo gout, where it looks just like gout, but when you aspirate, it's actually the calcium pyrophosphate dihydrate crystals and not the monosodium urate crystals. Acutely, again, the treatments are really the same for both. But as you mentioned, urate lowering therapy doesn't work for CPPD because it's not due to elevated uric acid. Most of these patients, so some people will just have one CPPD flare in their lifetime and that's it. And so a lot of these patients, you can get away with just treating their acute flare. You don't need to start them on long-term therapy. Patients who are having repeated flares, sometimes will use colchicine with variable success.
Okay. So no like great options.
Not great options, great options. But I would say we do try colchicine if someone's having recurrent flares.
Got it. Okay. Okay. So I think that's a really good overview for the like inpatient stay. So now let's say Mr. Smalls, we're getting him ready for discharge. And let's assume like he's on a really good heart failure regimen, because we did a good job with that part from all of the Curbsiders episodes we've done recently.
So many.
But now we also need to think about his gout and getting him ready to go home. So for him, we talked a little bit, it's his first flare. So how would you kind of set him up for discharge and what he needs?
Right. So because it's his first flare, he's not someone that I would think about starting allopurinol or urate lowering therapy. It really depends what you ended up starting treatment with. So if they are on colchicine, again, you want to continue the colchicine and instruct him to continue it until the symptoms are resolved. For prednisone, it depends how they're doing. So generally, if you start with 40 milligrams, my usual taper is I'll do 40 milligrams for 3 days, 30 milligrams for 3 days, 20 milligrams for 3 days, 10 milligrams for 3 days, and then stop. And so that is kind of a standard taper that you can give them when they're leaving the hospital. And then they can follow up with their primary care doctor, hopefully, within a week or 2 weeks to check in on them and see how they're doing.
And then primary care at that point would decide on what to do for urate lowering. Doesn't necessarily, because it's one flare, follow up with rheumatology.
Correct. Yeah. I think the majority of gout cases actually can be appropriately managed by their primary care doctors. Where rheumatologists can get involved is people who are truly refractory to the standard of care therapies, or if they need more advanced therapies such as the pegloticase, or inpatient people who are needing anakinra therapy.
Okay. And then I think there's for the outpatient side, then when they first show up, is there value at that time to get the uric acid? I'm really hung up on these uric acids.
So I would wait if you just got a uric acid when they're in the hospital, I would wait until the flare is over to repeat it. Generally, uric acid levels change within 2 to 4 weeks, so I wouldn't expect it to change sooner than that. Again, it could be artificially low if you check it when they first get out of the hospital, and so it's going to be tricky to know how to use that test to manage their gout long term. The other thing I do want to point out about uric acid levels is that you need a uric acid level less than 6 to prevent gout flares. And the reference range of most labs will tell you that it's normal up to 8, 8.5. And so, that's something also that we have to be mindful of, is knowing that really you need that uric acid less than 6 for us to prevent gout flares.
Okay. And then for Mr. Smalls, he was on the hydrochlorothiazide. Presumably he probably got off of it because of his heart failure regimen. But if he was going home on it, would you recommend stopping it because he had the acute flare?
So if there's an alternate medication that you can put the patient on, then that's great. We know that that's not always possible in every patient, though, and so we just have to kind of treat through it.
And then I assume like all of the other kind of counseling that should happen on the inpatient side should happen. So for him, he was still had some alcohol use. How impactful is that change as well, like to decreasing the flares and everything?
So I think it's great to counsel patients on the lifestyle modifications that they can make. The studies show that this may reduce their uric acid by 1 to 2 points. So if someone's uric acid is 13, again, it's great. We should always counsel our patients on that, but it's probably not going to be enough just to get them to a uric acid less than 6. So in addition to counseling them on cutting back on their alcohol consumption, other things that we recommend is cutting back on high fructose corn syrup. So I always ask patients, do you drink a lot of soda? Because that's another risk factor for gout. You want to counsel them on cutting back on red meat, and then certain shellfish can also trigger gout. So those are some other dietary modifications patients can make.
Okay, awesome. And then I think we already talked a little bit about, when it's recurrent flares and everything like that. So I think we can go to our next case.
Yeah, this one's switching gears a fair amount to kind of like what I like to call the room NOS case, if you will, which you're, I'm sure, very familiar with. So Miss Miner is a 35-year-old woman with a history of sickle cell trait and menorrhagia who presents to the emergency department with a resolving URI with severe lower and upper proximal muscle pain and weakness. She's noted to have a temp of 99.5, heart rate of 110, BP of 95/65, respirations 20, and a saturating 95% on room air. She says that she's been having bilateral hand swelling. She says she's had a sore throat, congestion, cough, but most of those symptoms are really on their way out, but has a lingering cough. No fever, chills, abdominal pain, nausea, vomiting, no blood in her urine or frothy urine. She states that the muscle pain and weakness started a few days ago, and she thought it would go away with some NSAIDs, but when it didn't, she just came in. Interestingly, her creatinine is normal. Her CK is normal. She has a respiratory viral panel that's negative. She gets some fluids for her elevated heart rate and gets brought in for kind of a further workup picture. Very similar to a patient I had recently who just really could not get out of, kind of classically couldn't get from seated position to standing, couldn't comb her hair, was having trouble with all of that. Her initial workup, like I said, the cultures and viral panels all negative, but her symptoms persist. I think we all think about infection initially, but when everything comes back negative, we start thinking, well, it's got to be rheum. And that's when I have to kind of just think through the very rudimentary rheum that I have in my brain, which is, like I said, rudimentary. So 1, is this okay? And 2, if that really is okay, what should I be thinking about in terms of workup?
Sure. So I think in this case, as you said, we're all thinking about infection first, even the rheumatology team. The person had preceding URI symptoms. They still have some of those URI symptoms, and at least they didn't mention that prior to this they had any joint pain, swelling, weakness. So the acuity of it in the setting of these other infectious symptoms really does make us think that some type of infection is triggering, their joint complaints. Many viruses, many bacteria can cause these symptoms. And so just because the RVP is negative and because the cultures are negative doesn't mean that it's not related to whatever infection they had. We know, the RVP only picks up, a handful of viruses. And so it might have been one that wasn't checked with the RVP. The other thing with the CK being normal and then with the pain that they're having, this makes you think it's less likely that this is an acute myositis. So myositis is really weakness. These patients really don't complain of pain and their CK levels should be quite high. So that steers us a bit away from thinking that this is an acute myositis picture. Other things, so with this patient, it would be ideal to take a really good review of systems to know if they had any joint complaints or muscle complaints before this acute episode. Rheumatoid arthritis, lupus, the inflammatory arthritis associated with rheumatic conditions, these tend to be more subacute chronic conditions. They don't tend to present with this acute abrupt onset of severe pain and swelling. So it's important to get that review of systems. Labs wise, there's nothing else that's jumping out. You said their urine was fine. I don't think they had, outside of the menorrhagia, any other cytopenias that were mentioned. But I would do a good review of systems and ask them, have you had any of these characteristic rashes? Do you have mouth sores? Are you having hair loss? Other things that could point you to an underlying more systemic rheumatic disease and not just related to the infection.
I was just going to ask, so I think that this situation comes up a lot for the hospitalist. And so I was just curious, is it better to, because the infection, you may never know what it is. So is it better to kind of, is there a time frame in your head that you're thinking, let me let this infectious course really run before I go and start ordering all of these tests that we're about to ask you about probably?
Yeah. So in arthritis that is associated with infection tends to resolve within 6 weeks, where, again, rheumatoid arthritis, lupus arthritis, et cetera, those are more long-lasting, more chronic. And I have actually seen infection-related arthritis last right up until that 6-week mark. So that's the time frame where you're starting to think, okay, this is a little bit too long. Is there something else going on?
That's interesting. So, because then it's like cough, like how you almost counsel patients for post-viral coughs. This can last for the 6 weeks, and you kind of would just say take whatever over the counter to treat through the symptoms.
Well, so that's yes, if they're an outpatient, sure, high dose NSAIDs, acetaminophen, that's great. This patient sounds like she's already done those things and it was so severe that she had to come into the hospital. And so there are cases that we do have to use steroids. Generally, I would recommend lower dose prednisone, so 15 to 20 milligrams to start with while they're in the hospital. And then taper is going to be based on how they're doing.
Yeah, that the patient I'm thinking of, it was very similar. Had just profound hip pain. So I guess we'll ask a little bit about imaging here in a second, but had imaging, came back negative, and then for some sort of bone infection or whatever. And so that's when Room was I think we need to pull the trigger on steroids. And it was a miracle,
Mm-hmm.
She literally was able to walk in a day or two, and just explaining to her, we wanted to make sure there wasn't some sort of raging infection
Mm-hmm.
before we started. Steroids obviously was a big part of our conversation because it's a young person that was otherwise so healthy. And so she was like, man, why didn't you start these 2
Mm-hmm.
weeks ago? Well, we wanted to make sure we didn't put you in harm's way, right? So
yeah, exactly right. We always want to rule out that there's an active infection, and giving them steroids isn't going to make that worse. So that's exactly what I would have done as well. Imaging, I think, can be helpful if it's specific joints. So if it's in the hands, if it's in the toes, kind of those smaller joints, it's unlikely that imaging is going to show anything in the acute setting. I think it can be helpful, though, especially if someone is having really severe back pain or they have point tenderness. Hips are tricky because you can't really see anything on exam with the hip exam. You really have to do that imaging to see if something is going on. Other joints, so if you're concerned specifically, do they have some type of weird tumor? Do they have an infection? The story is just not really fitting, then I think imaging can be helpful in those cases, more so because you want to rule out these other scary things.
And then just taking a step back again to the lab tests that we may or may not be getting. So we already got a CK to start, but I know that ANAs are not always the best plan because they're not the most specific, we all know, and then complement. Are those a good place to start? Are they a horrible place to start? Is there anything that might be better?
Should we call rheumatology before we order these things or after?
Yes. So
all of the above.
So I think the lab test that they got so far, so the CK, that was perfect because this patient was complaining of weakness. So that helps you kind of rule out or rule in myositis. Checking the urine, checking CBC, CMP to make sure there's not something else going on that's contributing. Those are all great steps. I would argue to check an ESR CRP in this patient to see, if it's inflammatory. And then those are also labs that you can trend when they go home as they're improving. The ANA, I would argue in this patient not to check it. And again, it's because of how acute the symptoms started. So unless they had something else that was flagging when you did their review of systems, they had some more specific features that make you think they have an ANA-related disease, like they've had longstanding Raynaud's, or they have scarring hair loss, they're having multiple mouth sores, they have really horrible Raynaud's phenomenon. Those are people that then I think it's okay to go ahead and check the ANA. I might just start with the ANA first, though, in this case. And if that comes back, then you can check the other serologies. But I would only check it if there was other features. I think the joint complaints in this setting are just not consistent with a chronic inflammatory arthritis we would see with lupus or rheumatoid, for example.
Awesome. So we talked a little bit about, I think, those labs. And sounds like if really in doubt, having like the rheumatologist like see the patient to kind of help sort through what would actually be valuable may be indicated. Imaging, if it's like for the specific questions that you have. So, and I think we talked actually in a way a little bit about like transitions of care for her because, that 6 weeks kind of timeline you may expect for the infectious things to wear off. So then at that point, I guess the follow-up you're setting her up with is primary care follow-up. If symptoms like are not resolving or things like that, then at that point kind of sending to room because you've kind of ruled out the infectious part, or?
So in the case that, like, I think where we would be going with this patient, they're severe enough that they came in the hospital, they're not responding to over-the-counter analgesia. I think it's appropriate to call rheumatology at this point. They probably would be the ones to kind of help you with the steroids and then also follow up as an outpatient. I know that not every place, though, has a rheumatologist. So I think following up with the primary care is also appropriate. And if symptoms seem like they're really not resolving, other things are coming up, making sure they get a rheumatology appointment on the books.
And then for the low-dose steroids you talked about, how long do you, like short course or taper again?
Usually you taper. Again, the course, the duration is really going to depend on how the patient's doing. I had 2 patients recently, actually, they were getting right to that 6-week mark, and the fellow was like, they're not better. Do you think we should start, immunosuppression? Should we start sulfasalazine or hydroxychloroquine? And really right at that 6-week mark, all of a sudden, they were just like, nope, I feel better. But usually it's a taper also.
Well, this has been really helpful. I think a really great couple of topics for us hospitalists that we just bump up against a lot. Any clear take-home points you want us to go home with?
So a couple of key takeaway points. For gout, the diagnosis really hinges on being able to aspirate the joint and identify the crystals in the joint fluid. So whenever possible, please aspirate the joint and send it for crystal analysis. You want to start treatment for gout as soon as possible. Colchicine is only going to work if the gout duration is less than 36 hours. So if it's more than that, pick another therapy. And then avoid pre-made steroid packs or short bursts of prednisone because these can lead to rebound flares. You really want to taper them depending on their clinical course.
Great.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Still hungry for more?
Yep.
Join our Patreon and get all episodes ad-free plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox, including our Curbsiders Digest, recapping the latest practice, changing articles, guidelines, and news in internal medicine.
And at the Curbsiders, we're committed to high-value practice-changing knowledge, and to do that, we need your feedback. So please email us at askcurbsiders@gmail.com. It also helps a ton when you subscribe, rate, and review the show on YouTube, Spotify, or Apple Podcasts. A reminder that this and most episodes are available for CME credit for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. A special thanks to our production team. Technical production is done by Podpaste. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Chris, the Two Man Chew, moderates our Discord. Stuart Brigham composed the theme music. And with that, until next time, and not in Vegas anymore, I've been Moni Amin.
And as always, I am still Dr. Meredith Trubitt. Thank you.
And good night.